Regarding the BOAST guidelines for the supracondylar fracture, assess the patient A&E, document distal pulsations and vascular and the distal pulsations and the nerve injuries. Document all the nerves, medial, ulnar, radial. The surgery should be same day or a next day surgery, but not overnight. Routinely should be done. Overnight operative intervention indications is number one is a skin compromise or threatening skin, which can be checked by puckering sign, perfusion problem, or absent radial pulse. Minimum of 2 mm KY should be used, and a medial device should be inserted using a technique which avoids the ulnar nerve injury. After the reduction, we have to assess the Bowman angle to correct the Bowman angle and to avoid cuvetus varus. Nerve injuries after surgical intervention. Nerve injuries are mostly nervopraxia unless they are post-operative. In post-operative situation, I prefer to explore it. Post-operative documentation of compartment syndrome should be done, and a post-op X-ray between 4 to 10 days to ensure that reduction is maintained, and VK-wire removal at 3 to 4 weeks time. If in the theater I am going to fix a fracture and I identify that there is loss of pulsations, I would prefer to remove my lateral K-wire and check the pulsations again by reducing the flexion, by extending the arm. If still it is not, the pulsation did not arrive, I would prefer to remove the medial K-wire as well and check the pulsations again and enroll the vascular team.